Thank you very much, Sabine. It's a great pleasure and honor to join you this morning. And just to start, these are my disclosures. Now, the title you've given me is a pretty challenging one, because as we're going to hear from this symposium, the spectrum of genetic disease is broad and getting broader by the day. So we have disorders of heart rhythm, of heart structure. Obviously, we have congenital heart disease. But so when I thought about this talk, I'm not a basic scientist. I occupy the translational space. And I think one of the challenges we have is to take the amazing developments that we now have in genetic technologies, genetic therapies, and apply those in clinical practice. But to do that, we have to persuade the clinical community that what we do in terms of genomics is important and relevant to patient care. And that is not an easy task, because I think there is still some doubt over two key questions, which I've listed here. The first is that actually in everyday practice, if you just use the normal tools that you have available to you, that we can identify genetic disease. And then the second, perhaps even more challenging question, is whether identification of that disease makes any difference to how you manage the patient. Now, I'm not going to try and talk about every cardiovascular disease. I think there's going to be some excellent talks in this symposium on channelopathies, cardiomyopathies, congenital heart disease. I'm going to stick to my area that I know best, which is cardiomyopathies, but I want to use this as a platform to illustrate, I think, some of the emerging themes in cardiovascular genomics. The term cardiomyopathy goes back to the 1950s. It was actually probably first coined by this guy, Wallace Brigden, in 1957. And he defined cardiomyopathies at the time in this way, that cardiomyopathies are disorders of the heart muscle which can be caused by any known disease process. And even back then he was saying that we should really not use this term idiopathic. Unfortunately, it's taken us about 30, 40 or maybe more years to really start shedding this term idiopathic. And I think now in the case of heart muscle disease, as in the case of heart rhythm and other phenotypes such as aortic disease, we're recognizing that a substantial proportion is actually genetic in origin. That said, in cardiomyopathy world and in other cardiovascular genomic diseases, we still describe or define our diseases largely by phenotype. So in the case of cardiomyopathy, it's basically a bad heart muscle which isn't explained by abnormal loading conditions, hypertension, aortic stenosis, or by coronary disease. And based on this morphological and physiological approach to classification, we describe patients who have thick hearts, dilated hearts, restrictive hearts. But we have tried over 2 decades now almost to try and emphasize the point that these are not diagnoses in themselves. They are descriptions of what you see when you take a picture of the heart. Once you've described your phenotype, then you have to start thinking about etiology and in particular thinking about genetic causation. I think one of the reasons why there is still a little bit of uncertainty amongst the cardiology community, the clinical cardiology community, about the relevance of these diseases is they're still seen as rare. This is an estimate from my local patch in London, which is sort of a population of maybe around 6 million people, where we've taken some of the published estimates for cardiovascular disease, which is genetic in origin, and you can see that we would estimate based on these that maybe we would have 30, 35,000 people out there who may have disease. I actually think probably, at least in the clinical population, these things may be less common than that. This is from a recent piece of work that we've done using electronic health records in the UK, looking at the prevalence by ICD-10 codes of the different major cardiomyopathy subtypes. And overall, we're getting about sort of 4 in 10,000 of the population. Interestingly, you can see, however, that the frequency of diagnosis has increased over the past 10 years or so. And I don't think that's because it's more common in the general population, but I think it is probably because there is a greater recognition amongst the clinical community and a greater willingness to use these diagnostic labels. However common it is, I think we've recognized for decades that cardiomyopathies are familial. It goes back way back to 1940s and earlier, where families were being described. And if we go back to one of the seminal papers in cardiomyopathy, this paper by Donald Tier in 1957, where he described the pathophysiology of the condition, here he described a family of where there were young sudden deaths. It wasn't, however, until the late 1980s that the first gene was identified. This was the first gene to account for a monogenic cardiovascular disorder, a gene which mapped to chromosome 14 and to the protein myosin heavy chain, or myosin 7, led by the Seidmans and clinicians such as Bill McKenna. Lots of excitement about that around that time, that the genetic basis of the disease had been discovered. But again, another recurring theme in cardiovascular genetics is that as soon as you identify one gene, you realize that in fact there are many other genes that are responsible for the phenotype. And in the case of hypertrophic cardiomyopathy, all of the other genes that encode the major proteins of the cardiac sarcomere have been implicated in HCM. Indeed, if we look at the spectrum of disease in hypertrophic cardiomyopathy, whilst sarcomeric protein gene mutations account for maybe 40 to 50%, we recognize there are a large number of genetic and acquired phenocopies, some of which are genuinely very rare, but some of which, for example, Fabry disease and particularly amyloidosis, are actually only rare because we haven't looked for them systematically. The discovery of genes and genetic mechanisms for the disease continues. As in other diseases, the focus has shifted from the coding regions of the genome to the non-coding segments, so the intronic segments, and now recognizing that mutations in the intronic segments are in fact responsible for disease, particularly in the case of myosin-binding protein C, another major gene in hypertrophic cardiomyopathy. And indeed, when you look for intronic variants, you can maybe find them in about 2% of patients with HCM, but particularly in people of Asian descent. Other genes that are described, some extent controversial, and this is because, as in many genetic diseases, and in particular in cardiovascular genetic diseases, we have age-related penetrance. And in the case of this gene, CSRP, not so common, but you can see that it's not really until the later decades that you start to manifest the condition, and it's particularly evident in men and less so in women. So if we look at large populations with these variants, we may in fact not detect a classical phenotype at earlier ages. And we also still have out there probably some recessive phenotypes. So in this gene, TRIM63, again, a little bit controversial, but relatively common in the population. 1% of well-characterized populations will have recessive mutations in this gene. So in the case of hypertrophic cardiomyopathy, we have this very complex genetic architecture. The majority sarcomeric genes. We have other genes implicated in the sarcomere and its associated proteins. And we have these so-called mimics of the disease, metabolic disorders or infiltrative disorders such as amyloidosis, Danon disease, Fabry disease. Now that's the story for hypertrophic cardiomyopathy, and we can make pretty much the same story for all of the other cardiomyopathy subtypes. So in the case of dilated cardiomyopathy, very simply defined by the presence of a dilated and poorly functioning left ventricle. This, I think, is the classical way of organizing the disease when we write review articles or chapters. It's helpful to a degree, but I think these kind of lists don't really resonate very much with clinical practice. I don't have many patients in my clinic, for example, with cobalt toxicity. What we've learned is, again, that if you go looking at families of people with dilated cardiomyopathy, around 1 in 4 of those families will have at least one other individual with the disease. And this has been a consistent signal now for decades. We've identified many different genes, and in many respects, dilated cardiomyopathy is even more heterogeneous genetically than hypertrophic cardiomyopathy, with mutations described in genes that encode the cell membrane, the contractile apparatus, the sarcomere, the nuclear envelope, the intermediate filaments, and cytoskeleton, and so on. More than 80 different genes. But if you perform genetic testing in people with dilated cardiomyopathy, it matches what you see in family studies. So in apparently sporadic disease, you can find a likely pathogenic or pathogenic mutation in 26% of individuals. If you have a family history of the disease, then you'll find a likely pathogenic or pathogenic mutation in half of the individuals. And again, this is a consistent finding. It's even more true of this one. This is probably one of the least common cardiomyopathy types, the arrhythmogenic right ventricular cardiomyopathy, defined by replacement of the free wall of the right ventricle by fat and fibrosis, characterized by ventricular arrhythmias. And we now know that in many patients, maybe as much as 60% of patients with this disease, we have mutations in the genes that encode the proteins of the intercalated disc, the structure that sticks adjacent cardiomyocytes together. So desmoplakin, desmogliin, desmocolin, and so on. But these are not the only genes. And once again, when we start looking, we find other less common genes which account for maybe 1–2% of disease, but are still out there as genocopies. So, if you come at this from a cardiomyopathy focus, each of these phenotypes are largely genetic diseases with a complex genetic architecture. But if we want to persuade our cardiology colleagues that this is important, we have to move into the world of general cardiology, because there the terminology is rates to ejection fraction, heart failure with preserved ejection fraction, heart failure with reduced ejection fraction. There, I think the perception is that genetics are really not that important. But in this study published this year in JAMA Cardiology, looking at a genetic analysis of two large randomized trials, the CHARM study and the Corona study, you can see here that mutations were being identified in about 3 to 4% of the total cohort. But if you had cardiomyopathy as the cause of your heart failure, you had a 15-fold chance of identifying a genetic mutation which was likely causative for the disease. And importantly, if you look here at the different genes that were implicated, it's the usual suspects, but these genes were identified across the full spectrum of ejection fractions. Heart failure with reduced ejection fraction, preserved ejection fraction, and this curious sort of intermediate mid-range ejection fraction impairment. So genetic disease is out there in the so-called real world. A theme which I think is now developing is this sort of the interaction between rare variants, which is what I've been describing to date, and common variants within the population, which, although they have a small effect on a phenotype, are much more common, so at population level exert quite a large effect. And that we have a large number of GWAS studies now that are coming through in heart muscle disease and heart failure more generally. Here in this nice summary from Connie Betsina and her team, you can see the results of large GWAS consortia and the UK Biobank looking at genetic traits that associate with cardiomyopathy phenotypes. And you can see that here in the case of hypertrophic cardiomyopathy, we can see SNPs that associate with increased ejection fraction, wall thickness, left ventricular mass. So all elements of the classical phenotype, suggesting that there may be some interaction between the rare variant which predisposes to disease and common variants that may determine its expression. The same is true for dilated cardiomyopathy, where we see variants that associate with left ventricular cavity dimensions and a clinical diagnosis of DCM. Another theme that's emerged from common gene analysis are that we have recurrent hits in genes which seem to have enriched polymorphisms within patients with, in this case, hypertrophic cardiomyopathy, but in DCM and other diseases, in fact, BAG3, ALPK, FHOD3. Some of these genes are interesting in that they span not only common variants, but also rare variants. So, for example, this gene, FHOD3, which has been described as a common variant in patients with HCM, also occurs as a rarer form of monogenic Mendelian disease. The same is true of this gene. This is work from our own group, ALPK3, a protein, the function of which is not entirely clear at the moment. But we've recently described this as a heterozygous, penetrant disease phenotype with severe hypertrophic cardiomyopathy, fibrosis, and heart failure. But it's also described as a common variant in the population, which seems to associate with HCM and DCM. And indeed is described as a recessive disease in children, where it's associated with a severe early onset cardiomyopathy and skeletal myopathy. So we see this spectrum of disease caused by variants within the same gene, ranging from the rare homozygous disease, if you will, to common variants that predispose. I think there's also increasing interest in the relationship between other common disease traits, particularly hypertension, obesity, diabetes, and the expression of rarer variants. So in the case of hypertrophic cardiomyopathy, we can see in people who have a clinical diagnosis that there is a relationship between the left ventricular mass and body mass index. We also see a greater prevalence of some of the classical aspects of the phenotype. So for example, in hypertrophic cardiomyopathy, outflow tract obstruction is actually much more common, interestingly, in obese patients. Now, this may be because perhaps these are not genocopies. This is, in fact, an acquired phenotype that relates to obesity. But I think we increasingly think that these common diseases, such as obesity, diabetes, hypertension, by themselves may cause hypertrophy through a variety of mechanisms, including redox signaling, abnormal endothelial function, changes in fat and glucose metabolism. But this effect may be magnified in individuals who carry a genetic mutation, whether that be common or indeed rare. And this idea of variants contributing to disease, I think, in heart muscle disease, I think is quite analogous to what has been described in ion channel disease. There is this concept of repolarization reserve, I think first coined by Dan Roden. And the idea here is that if you look at the action potential, and in particular repolarization, you have a redundancy in the systems that maintain the normal action potential, in particular the potassium currents. So for example, if you give a drug which blocks one of these channels, there is sufficient slack in the system to prevent prolongation of the QT interval. However, if you carry a penetrant mutation, as in long QT syndrome, or if you have common variants that affect the function of these channels, or if you have other comorbidities that may affect these channels, then your reserve, when exposed to a stress, is lost. So if you give a patient with one in this situation a drug which has the potential to prolong the QT interval, they may develop much more QT prolongation and propensity to arrhythmia because of this loss of their repolarization reserve. And what I think we may be seeing in heart muscle disease is exactly the same. What a myocardial reserve, or what I've started to call myocardial resilience. And I think evidence to support that comes from these recurring hits we get, particularly in GWAS studies, of the same proteins, whether it be hypertrophic cardiomyopathy, dilated cardiomyopathy, left ventricular non-compaction. For example, one in particular, BAG3, a gene which is important in some cancers, particularly leukemia, lymphoma. But this protein has multiple different effects in the cell, including regulation of autophagy, gene expression, apoptosis, sarcomere integrity, calcium metabolism with excitation, contraction, coupling. So I don't think it's difficult to understand how you could carry rare and common variants in this gene, which reduce your resilience to stresses on the myocardium, and this may be true of other proteins too. So that's a little bit about sort of the genetic architecture of the disease and what's emerging through studies on common variation. But as a clinician, and particularly as a cardiologist, what we always want to know is, okay, what difference does it make? Does it help me make a diagnosis, and does it help me treat the patient? And at least in cardiomyopathy, with regard to diagnosis, we're still heavily dependent on imaging. Yeah, we take pictures of the heart and we make a clinical diagnosis. And we continue to refine that such that we can start to maybe get closer to a tissue diagnosis non-invasively, so in this case using MRI to diagnose Fabry's disease, or indeed using nuclear techniques such as bone scintigraphy to diagnose amyloidosis. We are starting to get some convergence between genetics and the classical traditional approach to diagnosis in cardiovascular medicine. So for example, when we look at patients who have genetic forms of dilated cardiomyopathy, we're starting to recognize particular scar patterns whether it be mid-wall scar in the septum, these characteristic ring-like scars, which have a very high probability of association with particular genetic subtypes, and in particular genes like filament C, RBM20, lamin, and so on. And this, again, I've taken from Connie Betzina's recent review in Nature, which I think is it probably points to the future of how we may classify cardiomyopathies as we start to unravel the genetic architecture in greater detail, where you have this spectrum of common variants and rare variants with a variety of different expressions, which may be simply traits such as ejection fraction or left ventricular mass, all the way through to sort of more penetrant mutation phenotypes such as hypertrophic cardiomyopathy, dilated cardiomyopathy, left ventricular non-compaction. But in the clinic, why would we want to know a genotype? And this slide, which is a version of what I've been using for a long time, the traditional way of talking about this is that, well, we want to confirm diagnosis, we want to perform family screening, we want to determine or get some estimate of prognosis for that patient, and we want to prevent disease-related complications. And certainly in terms of confirming diagnosis, this can be helpful. It's actually probably more helpful in some of the rarer phenotypes, at least in the case of hypertrophic cardiomyopathy, than it is in the diagnosis of sarcomere protein mutations. But it does have an increasing role in confirming diagnosis. In terms of prognosis, for many years we've seen this graph such as this. This goes back to Hugh Watkins' study from 1995 when he was in the Seidman lab in Boston, describing families that had mutations in troponin T or beta-myosin heavy chain and showing very different outcomes in these families. I think if you fast forward to more contemporary data, I think we do see differences between carriers of a mutation compared to those individuals who don't carry a mutation. So the incidence of disease-related complications is higher in mutation-positive individuals. But I think what we really want to move towards, and which we are slowly edging towards, is something which is a bit more sophisticated, a bit more granular or personalized than that, where we don't just simply look at gene positive or gene negative, nor do we look at a single gene, but we look at individual mutations and try to predict outcomes from those mutations. And this is work from Lorenzo Montserrat, who was speaking at this conference, showing here different survival curves for patients with different mutations in beta-myosin heavy chain. And I think this is certainly our aspiration for the future. Where it already influences our practice, certainly in our own clinic, where we see a large number of patients with dilated and arrhythmogenic cardiomyopathy, is in decisions regarding ICD implantation. A recurring signal now is just as in hypertrophic cardiomyopathy. If you have a mutation, you have a higher incidence of sudden death, but it really depends on the gene. So you can see here that we see much higher rates of sudden death in patients who carry mutations, for example, in lamin or desmosomal genes such as desmoplakin, and also other genes such as filament C. So here, genotype is increasingly a critical part of our risk stratification algorithm for dilated cardiomyopathy. Conversely, we see other genotypes that are less associated with sudden death, but are associated with a much higher risk of progression to heart failure. So here's an example of that, our old friend BAG3 again, this time in the context of a dominant penetrant mutation, so a rarer mutation. And we can see here that the rate of heart failure progression is really quite high, particularly in male patients. I think genotyping is also now starting to help us triage a little better the individuals and the families that we follow in the clinic. So in the case of hypertrophic cardiomyopathy, if we look at relatives who carry a variant but are not expressing the disease, we can see after a period of 5 to 10 years, about 50%, in the case of men at least, will have expressed the condition. And it's only when they express the disease do they then become prone to the complications of the disease. So this gives us a justification, I think, for screening mutation-positive relatives and allows us to plan the frequency and type of evaluation. Yeah, but I'm a cardiologist, remember, and what difference does this make to how I manage the patient? Well, in dilated cardiomyopathy, you could argue not a great deal of difference. Here you see survival curves from the 70s, 80s, 90s, and 2000s for heart failure, sudden death, and there's been a dramatic improvement in all of these endpoints simply with the use of conventional heart failure therapy. Conversely, in hypertrophic cardiomyopathy, we still see high rates of heart failure, sudden death, and in particular in the case of heart failure, we have no drugs that are known to prevent this. And this is my final point really, is that drivers in medicine often relate to the identification of new therapies. And I think that's why genomics in cardiovascular disease is now such an exciting space. And you're going to hear more about this at the meeting. And it's because we're developing what I've called genetic therapies in its broadest sense, in the therapies that are guided by the genetic result. This is already the case in inherited arrhythmia syndromes. We already will tailor our therapy according to the genotype and in combination with the phenotype, for example, in long QT syndrome. We should perhaps be a little bit more proactive in our use of genetics in aortic disease, because we know that the natural history of aortic aneurysms and dissection is quite different for these different genetic subtypes. So there may be a case for earlier surgical intervention for some genetic subtypes of disease. We're already identifying familial hypercholesterolemia and developing new strategies, whether that be PCSK9 inhibitors or even gene therapy to knock down PCSK9 for those individuals who have FH. In cardiomyopathy, we've been a little bit slower. We've had a few phenotypes for which there are specific therapies, such as Fabry's disease with enzyme replacement therapy. The new poster child for this idea is amyloidosis, which can be caused by either deposition of light chains as a result of a plasma cell dyscrasia, but much more commonly due to deposition of TTR or prealbumin, which can occur as a genetic or acquired disease, and occurs because of dissociation of this TTR tetramer, which we can now stabilize therapeutically with drugs such as tafamidis, which are now being shown to improve mortality, reducing mortality by about 30%. And we also now have RNA therapies, whether it be silencing RNA technologies or antisense oligonucleotides, which again can knock down production of TTR and improve neuropathy and almost certainly cardiomyopathy. Even for the structural genes, there's now intense interest in development of therapies. So, for example, in laminopathy, a disease which maybe accounts for 5 to 8% of DCM, we understand its natural history from the development of AV block, AF, sudden death, and heart failure. It's already within guidelines for an indication for ICDs, but now we have drugs which are targeting some of these complex downstream mechanisms that link the external environment of the cell to gene transcription mediated by lamin. And we have drugs now in trials from like Pfizer, which are examining the impact of these small molecule therapies in reducing the heart failure phenotype. Even in my old friend hypertrophic cardiomyopathy, we now have really dramatic progress in therapy, targeting the basic underlying mechanism of disease, at least in some patients, which relates to an abnormal interaction between the beta-myosin heavy chain and actin, where it hangs on, if you like, longer to the actin filament, giving you a sort of a hypercontractile phenotype. We now have drugs that interfere with the actin-myosin interactions. You can see very dramatically on this well. Here, actin filaments moving across myosin fixed to a well without drug, and here with drug. And if you translate that into a randomized clinical control trial in patients with hypertrophic cardiomyopathy and obstruction, you now see reductions in obstruction, reduction in BNP, troponin, improvement in exercise tolerance. Lots of development in this area, both myosin activators, myosin inhibitors, and of course, gene therapy, which is perhaps the holy grail, looking to deliver wild-type gene into cells using various RNA technologies to overcome truncating mutations, silencing mutations. I'll skip this. Huge amounts of money now being invested in this area. So I think the future is very much moving from our traditional armory of interventions to a broader range of interventions targeted at the specific etiology, whether that be small molecules, RNA technologies, enzyme replacement therapy, chaperones, or even gene therapy. So personalized medicine has been a challenge in cardiovascular disease, but I actually think now we're on the threshold of this. So our job is to build that link between the clinical and the genomics community so that our patients can maximize their benefit from this new knowledge. I'd like to thank you, thank my teams who have to listen to this every day, and if we have time, I'm very happy to take any questions. Thank you very much indeed.
Well, thank you, Perry, for this brilliant talk, this overview who actually covered the whole history of HCM from the discovery of the first gene, MUH7, rare variants to common variants, and BUG3, for instance. Just one quick question from my side. In parts of the world where genetic screening, genotyping is still difficult, it's cost intensive, in HCM, which patient should certainly receive genetic testing in HCM? If you don't have, cannot test anyone you would like to test, but what is the most important patient to you?
So that really comes back to, if you're in a cash-starved clinical environment, then you have to show that the identification mutation is really going to change your management. And that's quite hard, because I think if something which is going to change therapy in hypertrophic cardiomyopathy, the numbers, the diseases are relatively small at the moment. Fabry, amyloid. In DCM, I would say it's probably more important, but there you've got to have access to defibrillators if you're going to put them in prophylactically. So I think the answer to your question is I think we have to somehow develop low-cost genetic testing strategies. It's the only way in which we're going to actually embed genomics into clinical practice. I think trying to target specific phenotypes is always going to be a rather limited strategy.